Hello, and welcome to today's presentation. My name is Kevin Borcher. I'm the Senior Director of Pharmacy Services with NEHI, the Nebraska Health Information Initiative, and the Prescription Drug Monitoring Program Director. Today we'll be talking about prescription drug abuse, prescription drug monitoring, and pharmacy technicians. The objectives that we'll cover today will include providing an overview of the prescription drug overdose problem across the country, and in Nebraska we can give you some specific numbers. We'll also be talking about what a PDMP is and how that data is reported by pharmacies and other dispensers, and we'll discuss the role pharmacy technicians play within accessing and using the PDMP. There are a series of questions that we'll want to cover today that you'll want to be made aware of. The first is question 1, what are different methods of combating the opioid crisis? The second question, what are common drug classes reported in PDMPs across the country? Question number 3, what are uses of the PDMP? Question number 4, how frequently do most states require pharmacies to report data to the PDMP? And question 5, true or false, pharmacy technicians have access to the PDMPs in every state. We'll be covering this throughout today's presentation. So to begin with, the opioid crisis has been going on for quite some time. In 2018, the number of total drug overdose deaths in the United States has reached over 67,000, with 70% of those attributed to opioids. In 2018, that number has decreased from 2017, but is still very significant. Within the period 1999 through 2018, over 446,000 people have died in the United States related to opioids. The number in 2017 is 5 times higher than what that number was in 1999. Now, we've seen some good information come out, and this is good news, where there has been a decrease in opioid prescriptions across the country. The information stems from a study that Blue Cross Blue Shield, one of the large payers in the nation, had conducted. And they looked at information going back 2013 to 2017 and identified that there were a decrease of 29% in the number of prescription fills for opioids for their members. And the total number of prescriptions that their members had had for opioids decreased 25%. Now, this is a limited population of just Blue Cross Blue Shield patients, but it does provide some information. A relatively recent article in the Journal of American Medical Association, or JAMA, is predicting that the crisis is expected to worsen, with an annual number of opioid overdose deaths projected to be over 82,000 by 2025 and continuing. And that's expected to have approximately 700 deaths between 2016 to 2025 related to opioids. But I had just said that the numbers are decreasing for prescription opioids, right? Well, yes, that's true for prescription opioids, but when you look at non-prescription opioids, you have other synthetic narcotics, such as fentanyl. Heroin has had recently a slight decrease, but with the synthetic opioids, the non-prescription opioid deaths have increased, and they continue to increase. So one thought is, what if we could have drug dealers report their street sales to the PDMPs? Great information, right? Just not very realistic. Now, one case that we've had with the PDMP locally is that, and this could happen with a pharmacy technician. A patient comes in with a prescription, usually, late on a Friday or Saturday evening when everyone is closed and you're about to close, with a prescription for hydrocodone. In this one example, that's a true example, the patient brought in a prescription and the pharmacy checked the PDMP for this patient and found that in 45 days, this one patient had doses of 540 hydrocodone tablets within that 45-day period from about 7 different prescribers and 6 or 7 different pharmacies. That, of course, alerted the pharmacist that something is probably wrong. So the pharmacist contacted the prescribers and the pharmacies that were identified on the PDMP report for that patient. That patient never showed up in the PDMP after that. So what happened? Did that patient receive treatment and went through a program for substance use disorder? Did the patient get caught taking illegal drugs, or either through fraud or forged prescriptions or through street drugs, and was incarcerated? Or something worse, did the patient overdose and died? We really don't know what happened with this example, but that's something that is found in the system and does occur. And everyone is focusing on the opioid drug overdose deaths, which is very important, and it is a crisis. But benzodiazepines, such as your alprazolam and diazepam, are also highly abused drugs, as they are considered within DEA class Schedule 4 for the most part. And you can tell by this graph how there's been an increase in drug overdose deaths due to benzodiazepines. And that number has also been very serious when it's in combination with an opioid. So opioids are bad enough. When they're taken in combination with benzodiazepines, your risk of adverse events, including death, increase. The opioid crisis didn't occur with just a single event, and it didn't occur in a short period of time. So it's going to take time to cure this, and it's going to take multiple faceted approaches to combat this. So what do you do? One piece is prevention. This includes drug take-back programs. Those drug take-back programs are coordinated by the DEA through local law enforcement in often cases, and they often use pharmacies to help this, where patients can take their unused, unwanted, unneeded drugs to pharmacies, and usually there's a local law enforcement officer there who will be able to take those, box them up, and properly destroy them. Patients can also bring their unneeded medications into in many pharmacies that have special receptacles approved by the DEA, with those pharmacies having authorization by the DEA. And then those receptacles are periodically emptied, and those medications are destroyed. Education is another important pillar for combating the opioid crisis. Education not only with healthcare professionals, such as physicians, pharmacists, or pharmacy technicians, but it also involves education for the public. And this education starts as young as elementary school. It could be from first, second, third graders through middle school and into high school and beyond. It's important to get the message across about the dangers of the drugs. And the whole slogan in the past of just say no, that still applies today. But it's hard to get kids to not do this with all the peer pressure and the activities that are going on. But it is very crucial to educate healthcare professionals and the public. Treatment and recovery is another mainstay for combating the opioid crisis. This is where a lot of money needs to be thrown into for those treatment and recovery centers. The federal government is doing some of that, but it isn't enough. Another method for treatment, at least on a short term, is using a drug called naloxone, or the brand name Narcan. This drug has been around for quite some time, and it antagonizes or blocks the effects of opioids. So if a patient is overdosed and still alive, maybe shallow breathing, maybe unconscious, giving naloxone to these patients can help bring them back around on a temporary basis until emergency medical services can be contacted and arrive. And there are 3 different types of naloxone available primarily. There's a needle and syringe. And for some of you that work in community pharmacies, you're aware that there is the needle and syringe that may come prepackaged, or you may create your own with an amp or a vial of naloxone with a needle and syringe in a package to sell to the patient. Patients don't need a prescription directly from their provider. They can, in most states, come into your pharmacy and request a prescription for naloxone. Many of the pharmacies have what's called a practice agreement or collaborative practice agreement with physicians that they work together in concert to issue these prescriptions for the patients, to run through the patient's insurance, because some of this isn't cheap, and that way it can be covered under either the patient's insurance or sometimes the patient's family member or a friend or caregiver that's coming in to obtain naloxone. That needle and syringe is probably the least expensive. There are discount cards available if your insurance doesn't pay for it, and you can get that for as low as $15 or $20. Then there's another product which is an injectable. It's called Evzio. It's very similar to the EpiPen, where you can place this device on the patient's thigh, press in, and it'll inject it through clothing even into the patient. It's very easy to use. It talks you through it actually. It's voice activated. And it does help very effectively. One of the problems with this that it's very expensive. Even with a discount card, it may be between $4,000 and $6,000 to the patient if insurance doesn't cover it. Fortunately, the manufacturer of this does have a patient assistance program that can offset some of those costs. But once again, it meets criteria that the patient has to follow before they can actually provide this to the patient. And then the third and most frequently used type of naloxone is a nasal inhaler. It's a small device that is similar to a typical nasal inhaler. If the patient is down, you can simply open the package, squirt it into the patient's nostril, and that gets rapidly absorbed to help bring the patient back around. The cost of this is in between those two. Typically, you'll find it between $120 and $150. And insurance is more likely to cover this. The naloxone nasal spray is often used by first responders, EMS, and law enforcement oftentimes will carry this. So a very effective product to be used. The fourth pillar is looking at the identification and monitoring of those patients who are on opioids and other drugs as well. This is where we're going to focus on the PDMP. So exactly what is a PDMP? Well, the Prescription Drug Monitoring Program is a large electronic database. This is a state-run program that allows each pharmacy or dispenser to take that data, bring it into the system electronically, and that allows providers such as physicians, nurse practitioners, physician assistants, and dispensers such as pharmacists to access the data. It also, in many states, but not all states, allows this data to be viewed by a pharmacy technician or nurse, which are often referred to as designees or delegates. And I'll get more into that shortly. Now, virtually every state has a PDMP that's state-run. The only exception is Missouri. If there's anyone on this presentation today that's from Missouri, the good news is that Missouri does have a PDMP. It's not fully state operated. It's operated by St. Louis County, and they're running this for about 80% of Missouri. So there are some gaps, but it is getting there, and there is hope that in the future legislation will pass so that Missouri is a blue state on the map, just as every other state is. The workflow is pretty simple. Patient will bring in a prescription. or the provider may electronically prescribe that medication to the pharmacy. The pharmacist or the pharmacy technician, if they're an authorized delegate, can look up that PDMP information on the patient to look for any unusual activity, such as I mentioned earlier, when a patient had 540 doses of hydrocodone in 45 days from multiple providers. If everything looks okay, then the pharmacy will fill that prescription. That information will be sent to the PDMP electronically, where that information is validated for complete and correct patient information and prescription information. That then allows the data to be viewed by a provider, by a doctor, PA, APRN, or their delegates, such as a nurse, to access the system. That can be reviewed. Those providers can contact the other providers or pharmacies on the patient's profile for additional information, increase that collaboration and communication between healthcare professionals. And then if everything is appropriate, the provider can issue a prescription, which then is taken to the pharmacy. If anything is not correct, or the physician feels that other appropriate treatment is needed, they can take care of that just by looking at the PDMP. So why do we need the PDMP in the first place? Well, we want to make sure the patient receives appropriate therapy. Oftentimes it's for the prevention of misuse and abuse of controlled substances. That's one of the mainstays of PDMPs across the country. It can also help to reduce fraud and diversion from those prescriptions that are brought in, maybe from a stolen prescription pad or other means for fraud or forgery, and then the providers can see that. But the overarching goal, in addition to those, is for patient safety. What type of information is sent to the PDMP from these dispensers? Well, I wanted to clarify a little bit about what a dispenser is. A dispenser is oftentimes referred to as a pharmacist to view the data, but it's also regarding a pharmacy or any entity that reports to the PDMP their data. So typically this is a pharmacy. Oftentimes it's a community pharmacy, maybe a mail order pharmacy. This information includes the patient information, such as a name, address, gender, date of birth, a phone number, and maybe a patient identifier. One of the biggest challenges is if a patient goes to multiple pharmacies and maybe their name is different. Maybe it's that pharmacy knows the patient and they go by James, or maybe they're at another pharmacy, that pharmacy enters them as Jimmy. Another may enter them as Jamie. So trying to put all this information together is important for proper patient matching. Pharmacy information, of course, is very valuable. So you can look on the PDMP to see if patients are receiving their prescriptions from multiple pharmacies. And that'll typically include the name and address of the pharmacy, as well as the DEA number, and it may also include the NPI if that pharmacy has one. The prescription information, of course, is key to this. It'll have the date issued or written. It'll have the date filled by the pharmacy, when that was processed by the pharmacy, the NDC, which then can be referred to through the name, strength, and dose form of that prescription, the quantity, and even the payment type, to know if this patient is a commercial insurance patient, private pay, which can all provide some telling information when providers are looking up this information on the PDMP. And then it also has prescriber information, oftentimes the name and phone number of the prescriber, as well as their DEA or NPI number. Which drugs are reported to the PDMP? Well, you can tell on the map, it varies a little bit. Oftentimes it's either schedules 2 through 4 or 2 through 5, depending on the state laws. Remember, this is all a state-run program, and those states determine what gets reported. So you'll have some states that will have just schedules 2 through 4. Other states which will include Schedules 2 through 5. Schedule 5 typically is looking at your coating cough syrups. And other states will include what's known as drugs of concern. Several years ago, before tramadol was considered a DEA schedule by the federal government, it was not thought to be highly abused, although reports came out to say the opposite. So eventually those states, even before the federal DEA scheduled it, those states labeled that as a drug of concern, and they were able to monitor that. There's currently the most common drug that is a non-scheduled drug that is being found to be abused by some patients is called gabapentin. This drug may be used for some neurological or even seizure disorders, but is still found to have some abuse potential. So many states will have that mandatorily reported in those states as a drug of concern. Then you'll see one state in the middle of the country that's purple, and that's Nebraska. Nebraska captures all prescriptions, both DEA Schedules 2 through 5 and drugs of concern, but it also has all non-controlled substances, such as an antibiotic, such as a diabetes medicine, and every other medicine that you can think of. Any prescription drug is captured by Nebraska's program. Now, I'll talk about that later on. It has very important implications that currently Nebraska is the first state, but there are many other states that are looking into this. And how frequently is this data reported? Well, typically, and you can see by this, 45 states are having their data from the dispensers reported on a daily basis. Oftentimes, depending on the state, that may be considered every 24 hours. It may be considered the next business day to account for those holidays and weekends, but it's typically reported daily, which is very important. You can see that there are only a couple of states that report outside or longer than daily, and then you see one state in blue, Oklahoma, which is leading the country in reporting the data at the point of sale, or what their law says within five minutes of that prescription being dispensed or sold to the patient. So this is something new that some states, such as Nebraska, are starting to catch on to and having that reported sooner than later. So by the time a patient would walk across the street with a forged prescription from pharmacy A and walks into pharmacy B, that prescription information will be identified if the pharmacist or the pharmacy technician looks up the PDMP on that patient. So very powerful information. I had mentioned before that pharmacies are types of dispensers that report to the PDMP. Once again, it's your typical community pharmacies. Some may require some hospital pharmacies to report, not the inpatient medications, but if a hospital pharmacy has outpatient medications that they sell to patients, those would be reported. Mail order pharmacies are oftentimes reported as well. Physicians who actually dispense prescriptions to their patients would be reporting to the PDMP. We're seeing that more and more frequently as well. It's not a high number, but yet it is occurring. And then something that you wouldn't think of very often is regarding veterinarians. There are about 15 states currently that require veterinarians to report controlled substances which are dispensed to their patients being animals. You may question why, and oftentimes it's because even though it's very legitimate for maybe a dog or cat having some problems around the 4th of July or New Year's Eve and needs a little bit of a benzodiazepine, such as alprazolam or lorazepam, they also may have broken limbs, or they may have surgery, and they do legitimately need opioids or other controlled substances to control the pain. However, there are reports where the patient's owners or clients are abusing the medications meant for their patients. So it's important now to capture what's being reported by veterinarians to make sure those patients or animals owners aren't abusing those prescriptions. Who can access the PDMP? Well, typically, as I mentioned before, prescribers, and that is typically physicians, nurse practitioners, and physician assistants. It may be some other classes depending on that state. Pharmacists are able to access the PDMP in almost every state. Delegates is also a category that I had mentioned. A delegate is someone who is authorized by a prescriber or a pharmacist to access the PDMP. These are most commonly nurses or pharmacy technicians. And that allows the pharmacy technicians to assist the pharmacist to give them more time to focus on the clinical activities. Now, in some states, law enforcement may have limited access if it's surrounding maybe an open case that they have, or they may need a subpoena or a court order by a judge to be able to access some information. And we don't see this in every state, but some states do allow law enforcement access. Payers are starting to be able to have access to this, primarily for the care of those patients that they're responsible for. But it's limited to only those members or covered lives that they're able to see. So let's say, Humana insurer would not be able to see a patient's PDMP profile that they're not covering on insurance. And then more and more states are allowing patients to be able to have access to their PDMP profile. And that could be in case the patients just want to see everything that is on their profile. They have the right to, because it is, in a sense, their data. And maybe they have some fears that someone has maybe done some identity thieving and are actually getting prescriptions filled under their name. Or maybe there was a prescription filled by one Jim Smith meant for another Jim Smith. And so those patients have the right to make sure that that information is correct, and they can request that if their state law allows that. The expanded use of a PDMP is starting to be seen, as I had mentioned earlier in the graph showing Nebraska as that purple state collecting all prescriptions. Currently, Nebraska is the first and only state that is doing this. It was fully supported by the state associations, the Medical Association, Hospital and Pharmacy Association for this. It's giving more information. It's the most comprehensive medication history available, and it's a great patient safety tool. It allows clinicians to make better informed decisions for their patients. It can also be able to be used to help identify potential drug interactions or even allergies from a medication used for multiple prescribers or pharmacies. One example that we've seen is if a patient is receiving an antibiotic from your pharmacy and you fill it and you did not check the PDMP. What happens after you hear a few days later is the patient was admitted to the emergency room, possibly even died. And one of the reasons that could have been is if that PDMP were checked, then you would have been able to identify that that antibiotic was properly prescribed. However, you didn't know that the patient was on another drug, a blood thinner called Coumadin or warfarin. And that drug can have some potentially fatal interactions or serious interactions as well, such as bruising, bleeding, and stroke when these are given together. So that's something very important from a clinical perspective, how the PDMP can be useful, and you as a pharmacy technician can review that information and then let that pharmacist know of what's being found. From you as a pharmacy technician, it's not your job to make clinical decisions, but you can certainly provide that information to the pharmacist and let them make those clinical decisions. It's a great tool for emergencies. Let's say that there's a flood, maybe a tornado or an earthquake. And all the information from the pharmacy system has been wiped out. It's not available. Or even from a hospital, if there's a power outage and that information is unavailable, the PDMP is going to have all that medication information for the dispensed prescriptions up until about a day ago, or even sooner in most cases. And so this is a great tool to look for that. And it's a very important tool for medication reconciliation. So for you pharmacy technicians that work in hospitals, you know MedRec. MedRec is really a disaster. It's a challenge, no matter in what environment you're in, no matter how good of an electronic health record you think you have, it's got some problems. This medication reconciliation is required by CMS, the federal government, for hospitals and other facilities to have a complete and accurate list of all medications that the patient is on. Now, oftentimes, your hospital system does have some pretty good information, but you know what I'm talking about to say that the information is not complete. It's missing data. And this gets to be a challenge when you're talking about those transitions of care, whether the patient is coming from home or a nursing facility to the hospital. You have those admission orders, and you're trying to figure out what the patient was really at home. You have skilled nursing facilities. If you're a pharmacy technician working in a long-term care facility, you know how important it is to have an updated list as soon as you can get that. And the federal government requires for Medicaid and Medicare patients that you have a full listing of those medications, and you actually need a diagnosis or a reason for use for those medications. Ambulatory surgical centers also need this, and those are quick turnaround places where you go in for maybe a shoulder surgery or something relatively minor. And so they'd like to know what medications you've been on, not only for your opioids, but benzodiazepines or other medications that could cause some interactions with anesthesia. So that's another important piece. And then simply your doctor's visits at the ambulatory clinics to identify prescriptions for other providers that those prescribers may not be aware of, to let those prescribers know that the patient has been seeing multiple providers and going to multiple pharmacies. This is a great tool for that. Now, as a pharmacy technician or a pharmacist, they can contact those other providers and alert them that if there is a problem, to make sure that they are aware that maybe there is some doctor shopping or pharmacy hopping going on. And some of the challenges more specifically with obtaining that medication history for MedRec is that it's only as accurate as the history obtained. You know very well that either from community pharmacies, it's hard to have patients who are good historians that can provide complete and accurate information, let alone if those patients are in a hospital and maybe they're unconscious, maybe they're elderly and too ill to provide that information, even if they're healthy. Some of us have difficulty giving a full account of all the prescriptions that we're on, including the dose and directions of that. You may have seen in the hospital where patients or their family members will come in with big bags full of prescription bottles, and they expect you to go through to try to figure out what's correct, what's accurate, what's up to date. And that's very time consuming to go through that. Not only do you have to do that, but oftentimes you have to call the pharmacies. There is one pharmacy, a hospital in a state, a rural area in Nebraska. Fortunately, they didn't have a lot of pharmacies, but there were still 7 or 8 pharmacies in that community. And every time a patient was admitted to their hospital, to obtain that correct and accurate medication reconciliation, they would call each of those pharmacies to find out which medications were most recently prescribed or dispensed for that patient. Now that takes a lot of time for you as that medication reconciliation technician to make all these calls for a patient. And it takes a lot of time for you as the pharmacy technician at the community pharmacy who's having to stop what you're doing, usually a very busy day, that's the way it always works out, pull up that patient's history, and then read off the list or print off the list and fax it to that hospital. So with the PDMP, you have all this information that the pharmacy technicians or the med rec techs can look up themselves. Yes, you as the pharmacy technicians or the med rec techs oftentimes are reviewing the EHR, but once again, this has only been as accurate as the last time that it was updated, which maybe was a few months or weeks ago. It could have been years ago. So you can't trust that until you know everything that's been updated. And then these admission and discharge orders is also a big issue, once again, with making sure that it's as accurate as possible. Trying to prevent adverse drug effects when patients are being admitted to the hospital. You want to make sure that those lists are accurate. When you're looking at the PDMP while the patient's still outpatient, maybe you'll help to prevent an admission. Or from those discharge orders, going to a nursing home for a patient or a skilled nursing facility, it's important to be able to read through those discharge orders, those discharge summaries. But if you have the PDMP, you can help to reconcile differences on that you might see some therapeutic duplication. Maybe the patient is on a certain blood pressure medicine at home. The hospital doesn't carry that, and they make a formulary adjustment to a different medication, and that doesn't get corrected upon discharge. So now the patient may have 2 blood pressure medicines when they go home or go to the nursing facility. And with that, that can provide some dangerous adverse events. It can cause the patient's blood pressure to drop and have that patient readmitted to the hospital. So what type of system do you want to be a successful medication reconciliation system? Well, you want an accurate list. You want to make sure that the drug name and dose form and the strength are all correct. You want a comprehensive list. You want to know everything, not just a few of the medications that the patient has had. You want an up-to-date list. With the PDMP, it's typically updated on a daily basis, sometimes even sooner than that. So it's much quicker than even some other medication history tools that you may have. And it provides information from all pharmacies, not just a single pharmacy. Ease of access within the clinical workflow is becoming more and more important to not only providers in the hospital, but also to pharmacies. So that wouldn't it be nice is when you're in the patient's profile, you have one button to click and it pulls up all the PDMP information. You don't have to go to an external website, log in, and then put in that patient's information again. This clinical workflow access is becoming more and more commonplace across the country. It's especially common within hospitals and electronic workflow systems, but it's also being seen more and more in pharmacy software systems. So you may be fortunate enough to be in one of those systems where the PDMP is available for that system. And then also not only being able to have ease of access to your state's PDMP information, but wouldn't it be nice to have access to other states' PDMP medications? This is also common throughout the country now and is available through most states across the country. Very important for border states. So if you're in a city or a town that's next to another state, you'd be able to look up that patient's information for that neighboring state and know if they're going back and forth between different pharmacies in different states. Now, it's one thing if you're working at a pharmacy chain, and you can usually see all the prescriptions from your pharmacy and other pharmacies in that pharmacy chain. But let's say you're at pharmacy chain A, and the patient is going back and forth between your pharmacy and then pharmacy chain B or pharmacy chain C. And you're not able to see that information unless you look up the PDMP. Well, another gap is what if the patient is going to another pharmacy outside of your state? That information isn't going to be readily available in some cases to your PDMP unless you have this ability for interstate data sharing. And then you can simply click a button or two and you'll be able to select the states that you want to see. This is also important for snowbirds. When patients, maybe in the winter, they go to some of the more southern climate states to get away from the cold weather. I'd be one to do that if I could. And this way, to have that interstate data sharing, if you're in one state, you can look up that patient's PDMP profile for that information. Remembering that those other states currently only have controlled substance information. Nebraska is the only state, once again, that has all prescriptions. So if you're checking a PDMP on that patient for another state, you're only going to see controlled substances such as opioids or benzodiazepines. Or stimulants is another class that you may see. Now, this system is very cost effective. Most of the time, it doesn't cost anything to sign up for access to this. It's either covered by state or federal funding, so it's not on a user access level. What opportunities specifically then are available for pharmacy technicians to use the PDMP? Well, first of all, typically you have to be delegated or authorized and under the supervision of a dispenser, such as a pharmacist or a prescriber. In most of your cases, it'll be a dispenser or a pharmacist. And you're acting as the agent of that dispenser. You're acting as their proxy to be able to look up the information for them. And you can provide that information to those authorized pharmacists. You can access the PDMP just as the pharmacist can. In some states, you may actually have to select the pharmacist you're acting as that agent of. So when you log in, there will be a list to say which pharmacists have authorized you and which pharmacists are you looking this information up for. So that's just a functionality within their system that may be required by state law. You can prepare this PDMP report, whether it's printing it out or showing it on the screen for the pharmacist to look up this information, then make those clinical decisions and decide what's the best course. Should they be calling other pharmacies or other prescribers to let them know they're seeing some unusual activity or trying to get clarification? They can contact the other prescribers and the other pharmacies, increase that communication between healthcare professionals, which is a good thing all the way around. And then that'll all help to have a better patient care, patient safety system. And preparing this medication history for medication reconciliation is being more and more commonplace. Right now, especially in Nebraska, with all prescriptions, the pharmacy technicians may use their PDMP to at least get a history of those controlled substances that the patient is receiving. And then they can focus on those other prescriptions and other means as well. What's the overall value of the PDMP then? Well, it's a very powerful tool. There's nothing else like it in the country. You can see the opioids, the benzodiazepines, and virtually all controlled substances that have been dispensed by pharmacies for review. It's a very comprehensive medical history for that medication process. It's very timely. Once again, it's reported daily in most cases. It's no cost to query this information, very easy to use, and it's becoming easier as we put the PDMP directly into the electronic health record and the pharmacy software systems. And this all centers around, most importantly, patient safety. This is all really for the safety and care of the patients. So now I want to go through the questions in a little bit more detail that we covered at the beginning. First question, what are different methods of combating the opioid crisis? Prevention, education, monitoring prescription use, or all of the above? The correct answer is D, all of the above. Each plays a very important piece as those pillars in combating the opioid crisis. Question 2, What are common drug classes reported in PDMPs across the country? Opioids, such as hydrocodone or morphine, benzodiazepines, such as alprazolam or diazepam, antibiotics, such as amoxicillin or levofloxacin, both A and B, opioids and benzodiazepines, or all of the above. The correct answer here is D, both opioids and benzodiazepines. Once again, Nebraska is the only state currently that's collecting antibiotics and all prescriptions besides controlled substances. Question 3, what are uses of the PDMP? To prevent misuse and abuse of controlled substances, to identify fraud or diversion, medication reconciliation, or all of the above. The correct answer here is D, all of the above. Each of these are appropriate uses and available to be used for the PDMP. Question 4, how frequently do most states require pharmacies to report data to the PDMP? Hourly, daily, weekly, or monthly? The correct answer here is daily, B. While there are some states that require hourly prescription or even shorter than that, such as Oklahoma, 45 states require daily reporting. And question 5, pharmacy technicians have access to PDMPs in every state, true or false? The answer here is false. While pharmacy technicians have access to PDMPs in most states, they do not have access in every state. That is a state-by-state law. Once again, thank you for your participation today. Hopefully you've learned something, and I appreciate that.